Welcome to Vital Signs, the podcast where we bring important healthcare conversations to our communities. This series is dedicated to keeping you informed about the latest healthcare topics, the vital role of community health centers, and the services available to you and your family.
Each episode, we're going to sit down with healthcare experts from Cornerstone Care to discuss the issues that matter most.
Hi, I'm Lesa Trenzo.
And I'm Courtney Downey.
Welcome back to Vital Signs.
So we wanted to say thank you first for tuning into our last podcast. If this is your first time joining us, though, you can head to our YouTube channel. We're also on Spotify, and we encourage you to give us a listen, a like, a love, and hit that notification bell, and give us a follow so that way you can see all the new episodes that we drop.
So May is Mental Health Awareness Month, and today's episode is going to be centered around talking about mental health care that can actually happen in your primary care office. So I'm joined today by someone who not only lives and breathes this work, but helped build it from the ground up. And it is our lovely co-host, Courtney Downey. Hey, friend.
Hi.
So welcome to the guest seat.
It's weird.
It is weird.
It's weird.
This
I don't like being on this side.
And we've had the giggles all morning. So this has been this is going to be a fun episode.
Experience.
It is experience. So tell everybody a little bit about your background.
Yeah. So I came to Cornerstone back in 2019. So I'm going into my 6th year now. Previous to this, I went to California University of Pennsylvania.
Ooh.
I graduated with alumni. I graduated with my master's degree in social work and went on to actually work where I did my internship. So I worked with victims of sexual assault and violent crime. I was a legal advocate there for upwards of 5 years, as well as a counselor there. So I had a wide array of an experience with working with victims of trauma. And then I took a leap. I came to Cornerstone and did something completely different. I had never worked in healthcare prior to here, although I have dealt with a lot of healthcare issues among family, friends, things like that. So it was definitely something that pulled at my heartstrings. And I took the leap, and I love it now.
6 years.
Yes,
so
6
you
years.
should.
Yes, and I was actually our first ever integrated care coordinator. So it was definitely a new concept to Cornerstone altogether when I started. And it took a lot of learning, a lot of twists and turns. There was a lot of ups and a lot of downs. But we're here today to talk about all the wonderful work we did.
Yeah.
So
Yeah.
yeah.
So let's jump into it. Let's talk about integrated care. So why is it so essential to primary care?
So integrated care is really all about collaboration and coordination among different healthcare professionals across different disciplines. So that could be specialists, that could be mental health providers, primary care providers, and really they're all sharing the same goal, and that's a patient-centered approach to health. So when it comes to mental health in particular, it's super important because about 75% of primary care visits actually have a focus on some type of behavioral health condition or complaint that a patient is experiencing. So we want to be able to identify that in primary care and treat it, especially in rural areas where there's a lack of providers. There's upwards of, 6.5 million, I believe, people that struggle with mental health issues in the U.S., 1 in 5. So we want to be able to identify those because realistically speaking, if you look at statistics, it takes upwards of 11 years for someone to actually come forward and say, I'm struggling with this. So if that place happens to be at their primary care doctor's office, we want to be able to be that warm handoff to whether it be another behavioral health provider or whether that be somebody within our own 4 walls that we can assist them with. But why it's so essential, particularly in a rural area, is that provider shortage. So what we want to do is be able to capture those patients here in our offices, treat them, but a big part of integrated care in Cornerstone in particular is also about helping our providers become more comfortable with the word mental illness and treating mental illness. What is it? How do we deal with it? What happens if somebody comes into my office and says, I'm struggling with depression. I thought I wanted to kill myself the other day.
Right.
How do we handle that?
Yeah.
And that's why it's so important for us to be educated in the primary care world. Along with the provider shortage in a rural area, we also have the stigma in a rural area where everybody knows everybody. Your neighbor doesn't want to be seen going into a behavioral health office. they're going to talk about you. They're going to share it with their neighbors, and then they're going to talk about you at the store, down at the local McDonald's. So there's a big resistance among our patients coming in saying, I don't want to talk about this because somebody's going to know. And myself included, I am from the community in which I work. So it was a struggle for me when I first started as well, to be able to go into a room with somebody that I know, teachers that I used to be a student of, my neighbors, my parents' friends. Those things are super important. Realistically speaking, we're trying to keep our patients in primary care who are experiencing mental illness, mainly because of the provider shortage, particularly in rural areas. So it's roughly around 65% of rural counties do not actually have a mental health psychiatrist available to people. And on the flip side of that, we also don't have availability of even a psychiatric nurse practitioner. I think that statistic is about 81% of rural counties don't have that. So the more we're able to identify this in primary care and treat it in primary care and try to keep them in primary care and reserve those appointments with our psychiatrists for patients that we're not able to find the right medications for, or they're still struggling even after we've done several interventions. Those are really the patients that we're trying to move into that psychiatric world where there may be more access to different medications, more treatment options, and even more access to our counselors. And I was going to kind of kick it back to you a little bit here and speak to your experience about being our behavioral health manager when you first came on with Cornerstone, and just the struggle of trying to get patients in and the complexities of what that schedule looked like.
Yeah, I mean, we're fortunate at Cornerstone Care to say that we have 2 full-time psychiatrists. And honestly, the expansion of telehealth in behavioral health really opened the door because now they're able to reach more people than we ever were before, from different areas, different counties, because, we're spread across 4 counties now? Is that where we're at? And, all these locations and needs, there are needs, intakes daily. And when we talk about the behavioral health schedule, from my experience in that department, when somebody makes that step and that phone call into the behavioral health office to say, I think I need to schedule a psychiatry appointment. I think I need an intake. And then you're on that receiving end on the phone to say, okay, I'm going to get some information from you. We have information for you to fill out. Your appointment might not be for another 6, 7, 8 months because, our psychiatrists are busy and their schedules are busy and they're seeing patients sometimes every 15 to 20 minutes in a 10-hour day. Like that's a lot of people. So it's, you hang up that phone or you hand them the packet when they walk in the office and they leave and they might not come back. We might call them to get that appointment scheduled or try to, and they don't come back. And that's the reality, that is the reality because you're, like you had mentioned, it's 1 in 5 adults. And when you're standing there ready for help and it's not there yet, you're just going to keep pushing it on the back burner. And I don't know if you covered the statistic yet, but I think we had something here where it was the onset of mental illness.
Yeah.
And,
11 years.
It's 11 years. Yeah. So if, you're kind of feeling a certain way or something's not quite right, it takes you 11 years to decide that I might have a problem. I might need to seek treatment. And to kind of hear that day where it's, realistically, people know they're not going to get an appointment today. But to know that they're not going to get an appointment for 6 months or more, that's a deterrent. That's, somebody might not come back. And we've seen it happen. We've seen the people slip through the cracks.
Well, and of those 1 in 5 people, only not even 50% of them actually actively seek mental health treatment. Once they identify, hey, something is going on and I don't feel right, only about 50% of them actually go and make that phone call. So to finally get to that point of making that phone call and then you're met with, well, it's going to be a while. Yeah. Being able to have a place to go in that interim period while you're awaiting those appointments. That's really what we're trying to do with integrated care. And integrated care might be newer to Cornerstone, but it's not new to healthcare in general. It's a little bit newer to FQHCs, but it started in the 90s. We tried it at one point. We had several different people in the role, and it was just falling on in the wrong areas of our organization, essentially. And now we really have gotten a grasp on it, and we're flourishing. We're moving forward. We're developing our own department, and it's really been life-changing for not only our staff, because we've been able to alleviate schedules. We've been able to alleviate patient wait times when they're talking to the providers, because I know we're going to kind of get into this, and maybe this is a good segue into what an ICC does. So we call them ICCs. They're integrated care coordinators within Cornerstone. But really, they're the first line person that is dealing with any patient that comes through our doors who says, yes, I'm feeling depressed. Yes, I have anxiety. Or yes, I'm struggling with substance use, along with an array of other things. But I don't know if we covered everything you wanted to cover for the first part.
I think so. Absolutely. You're hitting it. We're hitting it. So now I'm going to kick it back to you. So, okay, Court, like you started this conversation about integrated care coordinators. So there's so much more to what this role does other than being just this connection into mental health. You bridge into so many other different services. Can you shed a little bit of light on what these ICCs do? And, if I'm a patient at Cornerstone Care, how may I interact with one?
So right now, we have a couple of different focuses. So the main focus of an integrated care coordinator is that any patient walking through our door is screened every time, every visit, ages 12 years old and up, for depression and anxiety, as well as substance use. If those patients screen positive on those, even just saying that, yes, I had one day where I didn't feel right, they automatically get to speak to an integrated care coordinator. And that's face-to-face. They're coming in and they're talking with you through those, because right now our patients may be coming in for something completely different. They didn't even know they were getting asked that question. They're coming in because they have a sore throat. But we're screening them because we want to know what's going on. The whole person, not just, hey, I'm sick today. Because there could be an array of other reasons as to why you're sick, why you have developed heart conditions, why your diabetes is out of control. There are so many other factors that play a part in that, and that is really what that integrated care coordinator is there for. So just talking depression and anxiety first, they actually go in and they do, we call it a PHQ-2, is the actual screener that the medical assistants will do with the patients when they come in. If that is screened positive, the ICC will then go in and do what's called a PHQ-9 and a GAD-7. So basically, one is for depression, one is for anxiety. And all the screener does is basically give us a good indication of what is going on, what symptoms are they having. And it also helps us determine whether or not they're having more anxiety versus depression, because there are different medications that work better for one or the other. So they go through that with the patient. So they will go through every single question verbatim. They ask more questions, more open-ended questions about what is causing some of these symptoms. Have they been on any medications in the past? What worked for them? What didn't work for them? If they don't want medicine, why? What are their reservations about it? And then they also go into explaining what medications are. What is an SSRI? What does it do to me? Is it going to be on? Is this something I'm going to be on for the rest of my life? Because that's a common misconception, is that we have plenty of patients that life is just lifing for them and circumstances are hard. And they think that if I come into the doctors and I say that I'm feeling down or depressed or hopeless, that's automatically they're going to ship me off to a hospital. They're automatically going to shove medication down my throat. That is not the case. Those integrated care coordinators, yes, they're there to identify whether or not you need something like medication or a referral to a psychiatrist or a counselor, but they're also there to provide these short-term brief interventions for patients who are going through just circumstances that need just a little bit more help. So that's their main focus. They also, if we identify a patient in primary care that we do really think rises to the level of needing that behavioral health referral, they're that interim person who really does that warm handoff and says, okay, I've identified this person. They need to go see our psychiatrist or our counselor. I'm going to help you get in touch with them. I'm going to help you get your appointment scheduled. And I'm going to make sure I'm touching base with you in between all of that, because you might be waiting a while. And in the meantime, they're collaborating with their primary care doctor. So if there was a medication started, that ICC is constantly collaborating with the doctor. Hey, this patient is saying now that they're having some symptoms. Maybe we need to increase or decrease. And we've gotten really good at Cornerstone at actually utilizing our psychiatrist as a consultant until we can get into those appointments with him or her. And we might have a patient that we've tried on several different medications and it's just not working. But their appointment isn't until October, let's just say, or it could be earlier than that. But we're able to communicate with our psychiatrists, and they're able to say, okay, well, you've tried the X, Y, and Z. Let's try this. And our providers in the primary care world feel more comfortable with that, because now we have somebody who specializes in this saying, okay, let's try this until we can get him in for an appointment. And it's worked well. On the flip side of all of this, I always say to patients, my tagline when I go in the first time and talking to a patient, especially when we're identifying something outside of behavioral health, is that, your hurt knee, your sore throat is not the only thing affecting your ability to stay healthy. So we look at these environmental risk factors that are going on. I cannot consciously expect you to come in here and have your depression and anxiety under control, your diabetes under control, if you can't pay your bills, if you're stressed at home, if there's something more going on, if you can't afford your medications. So that's kind of where they come into play too. So at other federally qualified health centers, they'll have two. They'll have a care manager, and they'll also have what's called a behavioral health consultant. So behavioral health consultants are really that person, that those people that go into the room and really do that mental health part of everything. And then the care managers really deal with the chronic disease management, helping them understand different chronic illnesses and how to treat them. Ours are blended. So we always say, I think you actually are the one that say it, we know how to do a lot with a little.
Yep.
And our care managers, ICCs, behavioral health consultants, whatever you want to call them, do a lot with a little.
Yeah, you sure do.
So they're tasked with also being that care management part of everything and really identifying what's going on outside of these visits with that patient that's causing them to still experience depression, anxiety, or cause their chronic illnesses to get worse. One of the big name ones I like to highlight is diabetes. So again, if you can't afford food, how can I consciously expect your A1C to come in to be at a healthy range when you come in? And there's also a behavioral health part of that, because there's things called, behavioral health modifications. So a lot of patients don't know what is even causing their sugar to rise or fall, or, I know a lot of times I use the example of watermelon. So if it's summertime, we all love watermelon, right? But if you look as a diabetic, if you look at the glycemic index, watermelon's up there with donuts. Right. And that's an eye-opening thing for patients often.
Right.
So they're really tasked with helping patients understand what is causing their chronic illnesses to get worse and how to actually to deal with those things and to make healthier choices while also dealing with all of life's circumstances in the background. So we're talking inability to afford medications. So they're really setting patients up with patient assistance programs. We have something called 340B here at Cornerstone, and FQHCs utilize it often, which is basically discount prescriptions if you qualify. The patient assistance programs have been a godsend for our patients, particularly diabetic patients, because insulin is insanely expensive.
It sure is. I mean, the cost of insulin over probably the last 20 years has been insane. Mm-hmm. A friend of mine back in college couldn't afford to pay student loan debt and supply her insulin. Mm-hmm. And, what did she do? She rationed her insulin, and, she was abusing it. And what happened? She ended up falling really ill. And I mean, to the point where, those long-term misuses of her medication to just kind of, still keep insulin in her body, but not using it correctly led to her having to have a transplant, So, I mean, these are the things, and young, in her 20s, young. So yeah, I mean, this is a real problem that everyday people have.
Exactly. And I think that's why integrated care is so critical, because realistically speaking, you have 15 to 20 minutes with your doctor in that room. So as much as they love and care for every patient that comes through their door, they have a job that they have to do, and they have to cover many chronic illnesses in that 15 to 20 minute window. And a misconception among people who are getting integrated care services is that we're making all this money from this. What we do is free.
It's free.
It's what we do is free. And that's the beauty of it, is that we are so focused here at Cornerstone on really that patient-centered medical home model of, we want to be a one-stop shop for you. I know I said that in the beginning, but we really do. We want to make sure that when you come into our buildings, you know that you can talk to us about your mental health, your chronic diseases, anything going on at home, and anything in between. We want to make sure that we have resources available to you We're never going to ask you a question that we can't give you a resource for. And that's something that we learned through developing our program, is that, when we started asking some of these questions about environmental risk factors affecting your health, people were like, whoa, why do you want to know what my income is? Why do you want to know if I can afford my food or my utilities, what insurance I have, what my medications go? Why do you want to know all this stuff about me? And we do ask questions too about like intimate partner violence or caregiver violence, because they're very real. And people don't know that they can tell their primary care doctors these things. So it's really this new push in the healthcare field, new but not new. But people are finally getting used to being able to say these things to their primary care doctors and actually having somebody there to address it. And it's not just kind of getting brushed to the side because, well, we got to talk about your diabetes or we got to talk about your high blood pressure. We can talk about these things. I have somebody who works directly with me, and they're going to tell me all of the stuff going on with you, so that way I can tailor your care to you.
What would you say to somebody who finds these questions to be intrusive, or, they're in the office and I know we keep them in little folders or whatever when you check in. What do you say to somebody who has a resistance to say, I'm not telling you anything about substance use. I'm not telling you anything about my mental health. I'm surely not telling you about my income. I'm not telling you anything. What would you say to somebody who feels like it's intrusive?
So the way that we have it laid out is this privacy folder. And what we really hope is that, one, we have patients fill it out. But when we do have patients who are resistant to that, we don't expect our front desk or our medical assistants to talk to them about why they don't want to do that. So all of our integrated care coordinators are trained to explain the why behind these questions. We went through a lot of different trainings. We had, technical assistants, companies brought in to really show us how to ask these questions and explain the why behind them. So if a patient does not want to fill that out, that's okay. We don't force anybody to fill them out. Now, if you don't fill it out, we're definitely going to send somebody in to talk to you about why you don't want to fill it out, but in a good way. So we explain the why behind why we want to know about your income, because if your income falls within a certain level, especially with the manufacturers actually are pretty gracious with their income levels and assistance. So we want to know that information, because if, God forbid, you come in this office at any given time and say, I am struggling, many of the social services require us to submit income verification documents or a generalized range of income for a patient. So we ask those questions because of that, and we explain that. And some patients are still resistant to that, and that's okay. They may not want to give us that information until they need it, and that's fine, and we tell them that. As far as other things like whether or not they can afford food or, some of those other really sensitive topics, mental health, substance use, we explain that information does not automatically generate a referral anywhere. It doesn't go anywhere besides that integrated care coordinator and that provider. There are a few things, obviously, that if you tell us, we have to report because we are mandated reporters. One of the big questions I see patients really resistant to answering is on the PHQ-9. There's a question at the end that is, do you think that you would be better off dead, or do you want to hurt yourself in any way? And I always preface that question before I say it with, this does not automatically ship you off to a hospital. And many people think that if I say yes to that, then they're going to say, I need to go in an ambulance. I have to leave my pets are a big thing. I don't want to leave my pets. I don't want to leave my kids. I don't want to leave my family. They're going to ship me away, and I'm not going to be able to see anybody, or now I'm going to lose certain things in my life because I'm going to go to a hospital.
Well, and it's scary.
It is. And realistically speaking, more often than not, that question isn't. It's not to gauge whether or not we need to send you to a hospital right now. It's to gauge how bad things are right now. That have you ever gotten to a point where you, A, just felt like I want to give up, or B, that you really did develop a plan to end your life? And we do ask follow-up questions about that. A big part of integrated care coordinators' jobs is that crisis intervention piece. And I have sat with patients for hours and went through this with them and talked about, have they had plans? Have they ever had an attempt in the past? How did you do it? Do you have a plan now? How are you going to do it if you do? And I have had to send patients to the hospital. But after we actually have those conversations, we really get to the point of understanding the why behind going to the hospital, or the why behind, okay, I'm going to link you to crisis in the county. And you know what? They're going to check in on you tomorrow. Maybe it's a Friday. They're going to call you on Saturday and they're going to check in on you. I'm going to call you first thing Monday morning. I'm going to make sure that you're doing okay. And if we need to talk more, we can bring them back in on our own schedules and we can have those brief interventions with them more often than they may be able to get in with their providers. So all of that really is important, and there is resistance to answering those questions, and they're valid. They're valid concerns from patients because they may have had experiences of their own where they've been treated badly because of how they answered a question. And the integrated care coordinators really, they validate those concerns because they're real. And one of the things I say to patients all the time, particularly with that question, is that they become tearful. Somebody who is truly experiencing that feeling of, I would rather be dead than dealing with life right now. I explain to them that that is a normal feeling. And they kind of like, like, what? What do you mean it's normal? Although it doesn't feel normal, it's normal. What you're going through is awful. It's normal to feel like, you know what, it would be easier if I just wasn't here. And I think that that is really important for patients to hear because they want to feel validated in, hey, I'm here. I'm now finally saying this. Maybe we're the first person they've told, and I feel like I'm going insane. And this person in front of me said, you know what? This is normal. And they're here to help me. So I think that although there's resistance with answering some of these questions, some of these sensitive questions, even substance use, it's all in how you explain it and all in how you deal with it when you get those positive responses. You're never going to, at least in our office, you're never going to be met with judgment. You're never going to be met with somebody who doesn't know how to handle that question. And if someone doesn't know an answer, there are several people in the office that will find it. So I think that it's all about creating a safe space for that person, whether it be about a chronic condition, something going on at home, or mental health.
Yeah.
So, yeah.
That was great. Deep stuff. So to kind of segue into a different conversation, you mentioned being back in Cornerstone 6 years, and I started at the same time you did. Mm-hmm. And of course I was in the behavioral health world. So we kind of started this integrated care, department now, together. Mm-hmm. And it was a lot of work. I remember those early days. So it has grown so much. And I know I've heard it time and time again from providers, our senior leader team, where this is a role now that we cannot imagine having in this health center, this resource for our patients. So what's next? We always have to evolve in healthcare, right? With whatever's changing in the moment. What is next for an integrated care coordinator?
Yeah. So we had a lot of learning lessons throughout throughout the last 6 years. We've tried and failed a lot. Yeah. But I think that we're really at a point now where we've got a grasp on the mental health part of everything. And really, how do we work with our psychiatry department, our counselors, and really opening up schedules. And that's where I really wanted to kind of shed light on too, is that it really is a two-way street.
Absolutely.
So not only are we able to open up schedules by keeping some patients in primary care that we can, we're also, consulting with our psychiatrist when we need to. But also on the flip side of that is finding patients on their schedules who have done really well on their medications and maybe can be transferred back into primary care. And really we're treating that psychiatry visit as like a specialist visit where, okay, our primary care doctors are going to handle these medications for the next 11 months. And on that 12th month, you're going to have a appointment with the psychiatrist again. Yep. And we're going to go through those medications. And then throughout that period too, we talk about if there needs to be any kind of adjustments. Our psychiatrists, as well as our primary care doctors, they can talk.
And they do.
They do. They do. They have, not only do they talk amongst each other, but they have this now integrated care coordinator in the middle that can really keep an eye on, okay, this patient's calling in saying that they may not be feeling okay anymore. We might need a little bit of an adjustment. And that could mean putting them back on with their psychiatrist to do that med adjustment, or it could be them all consulting and saying, okay, this is the best plan. So there's a lot of different things that we have tried and done really well at. And that's really kind of where we're heading now is let's identify people on those schedules that we can really get back into primary care so that way we can open up more slots. But also, too, the big thing that we're moving towards is, treating substance use disorders. Yeah. So I know we didn't touch a lot on this at the beginning, but the integrated care coordinators really are the frontline person to identify patients with substance use disorders, whether that be a full-blown substance use disorder, whether it be opioid use disorder, whether it be marijuana use, that maybe you're just using marijuana as a coping mechanism. So really identifying the why behind use is one, but also two, alcohol. So when we talk about drinking, we do ask a question of, in the past year, how many times have you had 4 or more drinks on one occasion? If you answer anything but never, you're going to have somebody come in and talk to you. And it's not to pinpoint any particular patient, but it's really to identify those who are socially drinking versus binge drinking versus using alcohol as a coping mechanism versus somebody who really has a true alcohol use disorder and may need treatment, or just knowing that we have resources for you should you want to stop. And same goes for any other substance. So we're really moving towards honing in on substance use and identifying it and how do we treat it. And recently, I'm really excited about this one, we received a grant to be able to offer medications for opioid use disorder within Cornerstone Care. So we are able to offer our patients right now, maybe one day we'll be able to expand further, but right now we are able to identify patients in our primary care world who are struggling with opioid use disorder. I believe the statistic was at 40.3 million people in the United States suffer from a substance use disorder. And many of those don't seek treatment, or unfortunately relapse, or they've sought treatment and had a bad experience. So what we really want to do with our program is tailor that around the patient and what their needs are. So one of the big things that we've talked about when developing this program is, having this person in our office and putting up all of these different roads for them to travel down. So do we think that this patient is going to benefit from having counseling and psychiatry assistance, group therapies? Absolutely. Every patient who comes through our door, you, me, anyone, mental health, substance use, anything, benefits from therapy. Especially, I always say too, like even people in the field, every good social worker needs a social worker. Yeah. But we really have tried to tailor this around what that particular patient needs, and that's how we're building the program. So it's like we're identifying our patients' needs first and then building that program around them, rather than, hey, we think that this is going to fit everybody. So we've started developing that program, policies and everything around it. And we are ready to hit the ground running soon with identifying patients who need, and it would be particular buprenorphine treatment. Yeah. And really identifying what their needs are going to be, what programs we can offer them within Cornerstone, what partnerships we can have outside of Cornerstone, and being that one-stop shop for a patient where you can come and get all of your care here. And we're not going to judge you, because basically what it comes down to as well is that, we want to be able to say, okay, it's not treated like any other, it's treated like any other illness. So diabetes, you can come get your diabetes care the same day you're getting your substance use care, because it's the same. It's care. And we have several patients right now who are utilizing, medication assisted treatments elsewhere. We can take that over. And we can do all of that in one place, so you're not having to travel outside. Not only that, too, is really developing that program around them. So the ICCs are going to be essential in this program. Because, again, we're developing it around that patient. So that ICC is really figuring out what those needs are, whether it be, do they need to go to meetings in the community? Is that the best way that they cope? Do they cope well with group therapies? Do they cope well with individual therapies? What works best for them? They need some kind of structure. Sure. We just try to figure out what that structure looks like for each individual person. And
I'm going to use the phrase I think that I use for, you're going to meet them where they're at.
Yeah. Yeah. And that's the beauty of the program. And that's a little bit unique, because traditionally, way back when buprenorphine first started, you had a line out the door. And that's the picture that people have.
Absolutely.
And that's where I kind of want to squash some of that stigma associated with substance use treatment. Because it's not that way anymore.
It's not. And I think too, it's having that conversation of, I think we have this picture of what somebody who has substance use issues maybe looks like. Mm-hmm. And I think, the media has projected that a certain way, obviously movies, TV. And there's a stigma with that now. And I think a lot of people have learned that there are brothers, there are sisters, sometimes there are parents, our grandparents, our next door neighbor, maybe our teachers, it could be any member that's close to us. And everybody, I think, at some point knows somebody. Yeah. And the one thing that I've heard time and time again is, this really is an illness. And these are coming from mouths of people who I never would have heard say that before until it was impacted by someone that they love. Yeah. And I think when we start to peel back those layers and we have these conversations and we start to shatter that stigma, people are going to get more comfortable seeking treatment. And,
Absolutely.
and people have no problem saying I'm a diabetic.
Yeah.
I think people should be, or, people are getting a lot more comfortable now saying I have a mental illness. Yeah. And this is how I seek treatment. And I think, people are saying, this is how I'm losing weight, right? Yeah. Like there's all different ways now that people are coming forward to share their experience. And when you get somebody who maybe is struggling with substance, like they're going to be able to feel empowered to say, I am struggling with substance, or I have, and this is my story, and this is where I am now. And I think having these programs like this in there, it's going to empower more people to seek the help.
I agree. And we're not naive to the fact that this program may not be best suited for everybody.
It's not.
And I don't think there is any program that is best suited for everybody. And there's never going to be because, again, everybody is different and how they cope and how they deal with things are different. So they need different treatments. So we may have patients who identify this, and once we actually get through talking about what's going on, their needs, they may need something more like an inpatient setting. But that's where that ICC comes into play and is able to really identify what referrals somebody needs and getting them to that referral. Because way back when integrated care first started, or before integrated care, what happened? You went to your doctor and you said, I'm feeling depressed, or I have this going on. I'm going to refer you out, and nobody knows what happened with that referral.
Nope. You got a piece of paper.
Yes.
You were sent on your way to schedule an appointment. And that was it. Yeah. We're fortunate that we have these referral specialists that kind of help, schedule those appointments for you. So when you leave that office, we know. Yeah. We know that you have that appointment available, and
exactly
you have ways to get there.
Exactly. And then we are also following up on those referrals too. So we know that, okay, that so-and-so was supposed to have this appointment, or someone was supposed to call them. When we're following up with them and they didn't have that appointment, we can now figure out why that didn't happen. Was there a barrier? Was there a transportation issue? Was there a barrier with that appointment? Did they have to cancel for some reason? We're identifying all of that and making sure that appointment gets scheduled again. Yeah. And we're working with them to get them to that appointment. Yeah. So I think that's the beauty of having access to these care coordinators, care managers. And I think it's important to highlight that this is not unique to Cornerstone. It may not be at every primary care office. I think that there's a big push that more primary care physicians in any area are doing this type of work. But really, especially in the FQHC world, this is huge. And it's been a topic of conversation for a really long time. Yeah. So I don't want to just say that this is unique to Cornerstone, because it isn't. It's care that you can get many other places. And I think that when we go to these big conferences and we're all around, like health centers, our struggles are the same. Access to care, access to mental health treatment, substance use treatment, even access to social services in the area are lacking, particularly in rural communities. Urban communities are still having the same struggles. Sure. They're just dealing with different barriers. Yeah. So it's not unique to any area, to any health center. And we're all just trying to figure out the best way to meet our patients where they are, whether that be rural, urban, and anything in between.
And I think this is a good opportunity for, us to explain that by going to a community health center, we're talking about this whole patient approach, but it's affordable, right? So we take all kind of insurances, from no insurance to what's our director of clinical operations, Sarah, she always says, or the Cadillac version of health insurances. And, for those who maybe don't have insurance or they're underinsured, we have programs, right? We have what we call the sliding fee scale that helps make not only primary care, but behavioral health care affordable, which is probably one of the biggest, because I think there's always this stigma attached that I can't see a psychiatrist, I can't see a counselor, like that's expensive. Yeah. And you're right, healthcare can be extremely expensive, but we're going to work with you. And, there are options for payment plans, and there's just so many available resources that a community health center can offer you where maybe some other, larger healthcare organizations can't.
Yeah. We're the safety net for everybody.
Yeah.
Not just somebody who's uninsured, because realistically speaking, I can lose my job tomorrow and be uninsured. Yeah. but I know that I can go to a community health center and receive treatment, and it will be affordable to me. We also, too, have insurance navigators to work with individuals who maybe just don't understand how to sign up for insurance. We have so many patients who maybe fall within the Medicaid guidelines or Medicare. Some patients don't know that you have to actually apply for Medicare when you turn that age, and they don't know how to do it. They don't have support. Maybe they're by themselves living and they just didn't know. People don't check their mail. There's so many different factors that could be so simple or so large that affect somebody's ability to get healthy. Yeah. And that's really where I kind of want to leave the integrated care. Like, there are so many things that affect your ability to stay healthy. Yeah. It's not just genetic disposition to chronic illnesses. Right.
So Courtney, this has been a lot of information, telling a really great story. Speaking of stories, can you share a success story, maybe from somebody that, an integrated care coordinator has worked with and has seen those positive results come from?
Yeah. So I'm going to share one of my own. When I first started, I was working with a patient, and if she is listening, I hope she knows how proud I am of how far she's come. But I was working with somebody who, she would come into our office. She had been on tons of different antidepressants in the past. Nothing was really working for her. She went in and out of counseling. We identified very early on that she was struggling with some trauma, some just home life things going on. And she would come in and she would just sit in silence. And we would sit in silence the entire visit. And it wasn't until we really, really started to have monthly visits with her, then weekly visits with her, both myself as well as our nurse practitioner. We would sit with her every single visit, mostly in silence. And we would just wait for her to talk to us. And it happened again and again and again until she finally started to become comfortable with talking to us. And we worked with her through the whole trials of counseling versus not counseling versus prescriptions, not prescriptions. She has went through the ups and downs of, suicidality as well. We went through hospital stays together. And she kind of had a gap of care, not because she didn't want to come, but because she started working. She started to feel better about herself. She kind of got away from a tough situation. She was really doing well. And she finally came back to us recently, and she is doing so well. And really, for her, I really believe that relationship with her primary care office and being able to know that, hey, if I have something going on, even if I just want to sit in silence, I remember vividly, she would just sit in the room and I would try to talk to her about something that was uncomfortable, and she would just look off and be like, oh, you see that car over there? Or, oh, look at the paint on the walls. And I would bring it back, and we would talk. And we eventually got to the point where she would open up and talk to me about a lot more. Yeah. And it was heavy stuff. And I'm thankful that we were able to be that place for her. And realistically speaking, I would have never, before I started in this role, I would have never imagined that I could go to my primary care doctor and talk about all the things that are making me sad. Or all the things I've been through in my life. And the fact that she not only had an integrated care coordinator there listening, but her provider who sat there and made time weekly on her schedule for her to come back and have these silent sessions with her. And there were some other things health-wise that we dealt with. But really just having that time allotted to her, I think was really good for her. And it encouraged her to be able to grow and get out of a situation that she was in. And now she's flourishing, has her own place, has a partner, is working. And she came back, she looked healthy, she was happy, and she was not on anything anymore.
Wow.
No counseling, no meds, nothing.
But hopefully she knows that if, there's always access if she would happen to need it in the future.
There was definitely a big to-do when she came back in the office. Yeah. I mean, I got called out of her room, into her room, and we were all celebrating her.
Hey, if she's listening, I just want to tell her, I don't know you, but I'm proud of you, because those are huge steps.
They are.
And I'm proud of you. Because that's, this is just a snapshot of what you guys do. Mm-hmm. And, I working with the behavioral health team for as long as I did. And again, just hearing other providers and speaking on the behalf, you guys do fantastic work.
And it's not the social services and the mental health system. It's not an easy system to navigate. Healthcare in general is just not an easy system to navigate. And we, for a long time, expected patients to just know and understand how to do it. And it wasn't until we took a step back and was like, okay, wait, let me put myself in their shoes. It's not easy. And there's not a lot of resources out there. So where can we kind of fill those gaps is really what we're trying to do.
Yeah.
So, yeah.
Wow. Well, this has been great conversation. And I guess for our listeners today, if they are looking to access these services or, they want to start this conversation with their provider about their mental health, what should they do?
Tell them. Don't feel afraid to go into your primary care office and tell them everything that's going on. Because realistically speaking, they want to know those things. Because if you keep all of those things inside, they don't know what's causing X, Y, and Z. You might be going into that provider's office all the time and getting yelled at because your A1C is high, or your blood pressure is high, and they don't know all those other things are happening behind the scenes. Or you're telling them that you're taking your medicine, but really you're afraid to tell them that you can't afford it.
Right.
So they need to know those kinds of things to really help you stay healthy, whether that be mentally or physically. And as far as the mental health part of everything goes, if you walk into your provider's office and you disclose that you're depressed or anxious and they cannot help you with that, there's a bigger issue.
I agree. No, I completely agree. And I have heard that happening. I've seen that happen.
And you have to find the right fit for you. Whether that be primary care, therapy, you can go through several different therapists and psychiatrists.
Absolutely. Find the right one.
Yeah, and doctors, even within the same facility, because you're getting into the ins and outs of your life, the private details of your life with this person. So you have to mesh well. I always tell patients that they have to be your best friend.
Yeah.
Because
like shoes.
Yes, because you're going to tell them all of the good, all of the bad, all of the gross, everything. So you have to mesh well with them. And if you're not meshing well with them, try to look around. And again, it could be within the same facility, but sometimes you just don't mesh, and that's okay.
Yeah.
And if you don't want to be the person to have that conversation with us, with them, that's where these other people come into play. I always say that to our patients too. Like, if you go to our counselors and you're not meshing well with them, or even our providers, you're not meshing well, I'll have that conversation for you. You don't have to be put in that situation.
Absolutely.
And I think that follows suit in any place you're going to go.
Yeah.
Nobody wants their patients to feel uncomfortable.
No.
So,
and no one feels comfortable breaking up with their doctor either. It's not me, it's you, right? No one feels comfortable having the, and what happens? They just don't reschedule, and then they fall through the cracks, right?
Well, and the beauty of this particular being in a community health center, we have such a wide array of talents, and our providers in particular really do well at bouncing off one another and realizing, okay, I'm really good at this, you're really good at this, and let's figure out what this patient needs. Yeah. And they might be seeing their primary care doctor for this, but they might feel more comfortable talking to a nurse practitioner about this, or vice versa. So they work really well. They collaborate. Like I said, integrated care isn't just an integrated care coordinator. It's the whole team outside of Cornerstone as well. It's the whole specialist team, whether or not they're going in and out of the hospitals, really trying to communicate and collaborate and make sure that that patient gets all the care they need. And that is true. That's our nirvana, as our CEO would I hope he listens to this and loves that. But yes, we call it the ICC nirvana, where every patient feels like they got their needs met when they walk in the door, whether that be here or outside of Cornerstone.
Yeah. Hey, so. Cornerstone Care, we are small, but we are mighty.
We are.
Right?
Do a lot with a little.
We do a lot with a little. That's been a lot of information. Yeah. Do you want to give any final thoughts?
Yeah. So if you or somebody you know is struggling with any type of mental illness, chronic condition, I encourage you to, if you don't have a primary care doctor, you can access many different resources on our website. So you can go to cornerstonecare.com, shout out Cornerstone, and really access those services. But realistically speaking, if we're not the fit for you, if you're not in an area where you have a Cornerstone or you have a community health center around you, there are so many different resources online. If you are struggling with feeling down, depressed, hopeless, and need somebody to talk to, there's also 988, different crisis lines within the counties. But I can assure you that if you call one of our offices, we will get you to the right people if we're not the right fit.
And we'll drop some links, I think, to some resources in the body of the podcast. Yeah. So, if somebody's really looking for more, we'll even put a link in there. If you're interested in community health centers, like Courtney said, if there's not a Cornerstone Care in your neighborhood, we've got a lot of locations, so you might find us. There are other health centers nearby. I can put a link in there, and then you can research what community health centers are in your neighborhood.
Yeah.
All right. Well, thank you so much, Courtney. This has been wonderful. Mental Health Month is a lot. And I think the more we talk and have these conversations, we can start breaking that stigma. So I guess that's where we wrap it up. So be sure to subscribe to Vital Signs and wherever your podcasts are. And we'll see you next time.
Bye.
Bye.